Hello, welcome back to Big Fellas. This is the first of 3 special episodes. We have a doctor in the house today, Dr. Lisa Clift. How are you?
Yeah, good, thank you. Yeah, good.
Welcome to Big Fellas.
Thank you.
This wouldn't be a Big Fellas podcast without talking about football first. So, who's your football team?
So I was, so it's a bit complex for me, and I don't want you to take the mickey out of me for being a typical City fan, but so I was born in South Millwood, so right round the corner from Selhurst Park. So I'm actually a Palace fan, yeah. But my husband and my 4 children are all massive City fans. We live 20 minutes from the stadium. I've lived in Manchester for like 20 years, so I've now become a City fan. So I know you'll all be like, oh yeah, typical Emory Hunter, typical plastic.
You
Yeah.
You remember the bad days then, do you? You remember prior to 2008?
Yeah.
Thing is though, it's a really good time to be a City fan. And so you do live local club. I can't really say that. Like we were talking before, my eldest son is a Man City fan and we live in Paint.
Yeah.
And I'm always calling him a glorious supporter. But then he points out, well, Dad, you're a Liverpool fan.
Yeah.
And we live nowhere near Liverpool, but I've always been a Liverpool fan. Yeah. And it's a good time to be a City fan.
Yes.
Yeah.
So, I mean, yeah. So we've, as I was saying to you, we've got 4 season tickets. There's 6 of us in the family. We're always fighting over the tickets. The kids are always like, well, you're not even a City fan, so you shouldn't have a ticket. And then I'm like, well, I'm only going to go to, the better match. Well, yeah.
The big games.
The big games. Yeah. So, like, we were having a big fight over Real Madrid and City last year, and, yeah. But it's...
I love kids because they're like, you shouldn't go, but I bet you pay for it.
Yeah, so we pay for the tickets.
Yeah.
And now because they're old, so they're 22, 20, 18, 16, we don't need to go. So now my husband and I, having paid for all the season tickets, and now City watching the match at home.
On Sky Sports.
And they're at the stadium.
Oh,
so, yeah.
Brilliant.
But it's good. As I was saying before, it's something we can do as a family, which is really nice. So,
fantastic.
Yeah, some away days and stuff.
No, we'd love to talk football all day. We really would. That's my favourite topic of conversation. But we are here for Big Fellas and obesity. We haven't actually spoken about obesity since doing this podcast, which seems crazy. But today, having Lisa here with us, we're going to do an episode on obesity as a disease, as something that we hope can be treated. Yeah, let's dive into it, shall we?
Okay, yeah.
So let's just talk about obesity. What is obesity? Should we start there? I mean, a very basic one.
Yeah, so I'm a GP and I have trained as a lifestyle physician and I've now got a special interest in obesity. And as we were saying before, I work with men most of the time. So I've become very interested in obesity in men because there's more obesity. So 69% of men suffer with obesity, overweight and obesity. And yet only 11% of men will go on a commercial weight loss program. Only 10% of GPs will refer men to specialist services. So there's more obesity in men than there is in women, and yet there are the services there to support them. So they're sort of classified as it's an unmet need. So it's very important for men. So back to your question. So there are definitions. And at the moment it's done on the BMI. So between 25 and 30, if your BMI is between 25 and 30, you're classed as overweight. One thing that's very interesting is the terminology. So it's changed. So to help with the stigma of obesity, people in the obesity industry, and also it should now be trying to, throughout everyone, to reduce stigma, is to refer to it as a person living with obesity, rather than saying I'm seeing an obese man, you're saying I'm seeing a man who's living with obesity or living with overweight, because
less of a label then, isn't it?
Yeah. So it's like saying diabetes. So you wouldn't say I'm seeing a diabetic person, you're seeing a person with diabetes. So to help with the stigma. So
describing it more as an illness rather than a
yeah.
Do you think that's why so many men don't seek help, because of the stigma around it?
So possibly, I don't know. So that would be putting that question back to you, really. So as men who have, lived with obesity, what would you say?
Yeah, I would agree. I think it is.
Yeah, I mean, I think you're actually right. They're in the services there for guys. I just accepted I was a fat guy, and I've lived with it all my life, and so it was just, that was my identity and who I was. And I mean, I knew that I was a bit heavy and I wanted to try and lose a bit of weight, and I've done various things over the years, but it was just part of who I am. I was a big guy. I was the fat funny guy within my social circle, and I'd often almost go out on the attack and preempt it and make a joke about myself being fat to stop someone sort of like targeting me first. Interesting. I was thinking about this morning. Again, it's something that I've always done. It's always been like a defensive measure. I was at a Casanian gig in the summer. Me and my mate, we chatted to some girls, and my default fat guy joke dropped about myself. I've just let it out just because almost I think it was nerves or what. And I said it, and then they looked at me and goes, "But you're not even fat." And I'm like, "Oh my God, I've actually got over this." And it was one of those moments where I realised the weight loss has worked. But yeah, just going back to it, it is just a bit of stigma. The stigma is there, and it's become part of my identity almost. What would you say?
Yeah, same. Adam, I mean, I still probably obese if you on the BMI scale, but I've come down a lot. I think it sort of over the years, especially going through sort of childhood into adulthood, it's just part of you, isn't it? And you kind of just accept it. And I don't know. Yeah, I suppose those jokes, they're almost like a defensive mechanism.
Yeah. So it may be the misconception that men don't care what they look like or how they feel, and it's all maybe women care more, but that's not right, is it? And like you said, there is a lot of banter around living with obesity and living with overweight. And it goes to, it's sort of links in with, say, for example, the Movember thing and men's mental health, is that men make jokes and have a laugh and have banter, but do you actually talk about your feelings? And with trying to improve mental health in men, it would be nice for men to actually have more sort of deep conversation. So with the Movember organisation, they talk about Alex, don't they? So the mnemonic for, ask the question, listen to what the answer is, encourage people to, if you find someone's suffering with their mental health, to encourage them to do something about it and then check in with them. And then, they always say that, how are you? Yeah, I'm fine with it. Yeah, but how are you really? Yeah. And then you get to, actually, I'm not that great. I've not been going out. I'm not seeing my mates. So there could be a lot of banter around overweight and obesity, but yet actually, so, when I see men in my clinic, we talk about their history. So we talk about their weight history, and, that we'll go, I say, right, go tell me, and you did this in your first episode tell me about when you were a kid. Were you overweight when you were a kid, or, and it's almost like you can almost see the tears well up in people's faces when they talk about, actually, I've been bullied my whole life about living with overweight or obesity as a kid. And, I see men who are in difficult positions now, and you wonder, has that come from the way they were treated as a kid.
Yeah.
And unfortunately, we're going on talking about stigma now, but it's everywhere. So people get bullied for their weight, they get treated differently, maybe in people's subconscious, there's subconscious bias.
Oh, yeah.
Whether, getting jobs, even the medical industry do it.
Yeah.
They kind of assume that, there might be assumptions that are made. For example, you're lazy, you've got no willpower, you're weak, all those things, which is absolutely rubbish. So
I had a podcast not that long ago, and it was with that very pleasant human being, Katie Hopkins, and she said she would never hire anyone overweight in her business because she said exactly that.
Yeah.
They're going to be lazy, they make poor decisions. I can't afford to have that in my business. And I was like, wow. And I said, well, what if you're in IT and you're the best coder, and okay, your belt size is a bit bigger, does that mean you wouldn't hire them? That just seems madness. But you're right, there's a stigma there, and people do make those judgments, don't they?
Yeah.
One of the things that actually spurred me on with my weight loss, amongst other things, because there was actually, my GP was amazing, but one of the things that spurred me on with my weight loss was the fact that I was setting up a business as well. And there was that imposter syndrome that says, you're fat, no one's going to listen to you. So I do quite a lot of public speaking at the moment, and I feel a lot better doing it now, even though, like I said, I'm still overweight. I'm a much healthier weight, and I feel much more confident as a result of that. And it is all down to that stigma.
Yeah.
And, if we're talking about marketing, which is what I do, your weight means absolutely nothing. It's your knowledge that people are there for. And to other people, they probably might not even think about it, but in your head, it's a nagging thought. And it really, it pushed me. It took me longer to go self-employed because of that, I think.
Yeah.
And we kind of know that overweight and obesity causes misery. It causes misery to people. It's, as you say, it reduces your self-esteem, your self-confidence, your mental health, and what happens is that the converse thing happens that drives you to eat more. So because you're
trying to
eat to comfort. So I suppose it is really important that we are careful with our language, how we refer to people, and also how we treat people. And that's why it's so important, why it's such an important subject as a medic, and because of, one is preventing obesity in the first place and then treating obesity.
Okay, cool.
And I think the prevention thing is always going to be better to try and prevent, isn't it? Yeah.
So looking at the causes of it, so basically the definition of, obesity is it's a chronic lifelong illness, which is more prevalent in genetically susceptible people who are living in an obesogenic environment. So, there are over 1,000 genes that can affect associated with obesity, and we all live in an obesogenic environment. So,
what is an obesogenic environment?
So,
how do you describe that?
So that is living in a world where we are flooded with food. There's just an abundance, an overabundance of food that's easily and readily available. It's marketed to make you want to eat it. So, all the marketing strategies, which you would know more about, are all geared towards making you want to eat, especially as, we talk about sort of ultra-processed food, quick and easy, convenient, cheap, food that makes you want to eat loads of it and is not very good for your health. Yeah. So other causes would, so other things that affect it other than genetics and the environment would be, lots of different factors, like we talked about mental health, talked about, so living in poverty. So there's, good evidence that shows that people who are living in poverty have got increased rates of obesity. Where you live. So if you haven't got access to open fields or, parks and place to go and play, that's going to sort of increase your risk.
On the face of it, seems odd because you'd think in poverty, food will be less available and the food banks and things like that. But I guess if you're in poverty, you still eat, but it's the cheapest of the cheapest, and it's highly processed, and it's not really real food, I guess, is it?
Yeah, no.
And when I'm seeing that the rich will often eat better because they can afford to eat better. They shop at better places, they buy better ingredients and so forth.
Yeah. So. And some people who are very thoughtful might say, oh, we'll just eat from, if you cook from scratch. But what they don't realise is that if you're living in poverty, then you might not have access to a fridge or an oven or a microwave or
pots and pans.
Pots and pans. You can't you can't batch cook because you might not have somewhere to store it afterwards. And I was listening to, we had a lecture from Michael Marmot, who is, obviously talks a lot about social inequality. And, as he was saying, the numbers show that if the people who are less well off, the proportion of their money that they spend on food is so much higher than people who are not in the wrong deprivation, because see the proportion you've got to spend on food is so much less compared to your general sort of income.
So moving on then, so why is preventing or treating obesity important?
So there's two different things, aren't there? There's the prevention and there's the treatment. So in terms of prevention, I think it's all about the environment. So there's a recent statement that came out from the obesity. There's a report that's recently just come out from the House of Lords looking at diet, food and obesity, and basically they've said that it's all about the food industry and it's all about the food. And so that's sort of from the prevention point of view, so that the blame isn't with the individual, the blame is with the food industry. So they're creating food that is basically destroying people. So the importance of it from a medical perspective is all the sort of conditions that arise as a result of obesity. So things like high blood pressure, type 2 diabetes, increased risk of cardiovascular disease, mental health problems, joint problems, all those sorts of things are, obstructive sleep apnea, all those things are associated with overweight and obesity. So that's why it's important it's not just about what you look like, which is important to people, but it's about what the complications of living with obesity are.
So it's not only better for the individual to be healthier, obviously you feel better, etc. But it's, for society, we know, don't we, that the NHS, for example, probably spending a lot of money on this stuff, on the later down the line issues that come with it.
Yeah.
So, everyone is for the whole of society, isn't it?
Yeah. So it costs in the UK, in 2023, it cost the UK £98 billion. And that's from the cost of the NHS, the cost of social care, the cost to mixed earnings, so lots of productivity. So generally it has an impact on not just the individual, but it's having a big, I think if you're living with obesity, you're more likely to have 4 sick days in a year. So that loss of productivity.
So actually, a sensible government would be looking at some serious investment into getting on top of obesity. To help the benefits later on. Yeah. I think we spoke a few months ago, a while ago now, blue zones. I don't know much about them. But,
okay.
My understanding, and you'll no doubt know more than me, but is that these areas are areas where people eat a lot fresher, generally have a better diet, and they want to live longer.
Yeah. So the blue zones are 5 different areas around the world where they have found that they have got the highest proportion of people living into their above 100. And so I think his name's Dan, I can't remember his surname is now, Dan White or something like that. He has spent his life looking at it. Why is it these people in these different areas are living longer than anyone else? And they're all different areas within the world. So there's like one in Sardinia, one in California, one in Japan. And it's like, right, what is it? Let's look and see what have they got in common? Are they all eating the same thing, or are they doing the same thing? And basically, there were different factors. So they have a good diet where they tend to eat whole foods that have, locally produced, that sort of thing. So they have, they do exercise. But it's not sort of, they go to the gym, it's not that at all. It's they have exercise in their day-to-day living. So, for example, in Sardinia, they show that it's where they live in Sardinia, it's like on a hill. So you have all these old people who are literally just walking up hills the whole time. So that's keeping them strong, it's keeping their legs strong, their glutes strong. In Japan, they tend to have low tables. So instead of sitting on a chair, they're sitting on the floor. So all the time they're up and down off the floor. So they're, keeping
muscles get used.
Yeah. So, so that's diet and exercise. Also social interaction. So they tend, they looked at families who tend to have multiple generations living in the family. So they are, so the children are benefiting from their grandparents being there. The grandparents are benefiting from helping the children with their homework, taking them to the park. So it's kind of keeping them young and fit and mentally active. And also, so alcohol, you could say, is it because they don't drink alcohol? Well, that's not true, because they do drink alcohol, but they drink it in a social way. So they're having nice family meals with a glass of wine. So it's drinking in a social context, whether it's, and obviously not drinking to excess.
Yeah.
So it is really interesting. Yeah.
And I think that's what we need to be more like here, I suppose, isn't it? We kind of need to take that, I suppose they are taking those lessons, right, and thinking, how can we make that more normal for people in the UK?
Yeah. Yeah.
Kind of moves on to the next point. So what is the treatment for obesity, and is it purely a lifestyle? Is there any other way, and how would you sort of talk about that? I'm a lifestyle physician, okay, and lifestyle is as a lifestyle physician is the type of medicine where you're using sort of evidence-based behavioral change techniques. So you're looking at trying to help people change their behavior, and you're focusing on the 6 pillars of lifestyle. So that's diet, exercise, mental health, social interaction, avoiding substance misuse, and social interaction? Yeah, social interaction. So they're the 6 pillars of lifestyle medicine. So the treatment would be helping people sort of make behavioral changes, but also looking at someone's diet, looking at their physical activity, and looking at the habits, trying to help with habits. We're trying to implement sort of lifelong new habits, which I think one of your podcasts was about, wasn't it, the other day, about implementing habits. So that's one aspect of it. So looking at the lifestyle changes, but you're only going to get a certain percentage of weight loss through that, which is, so roughly it's sort of between 5 and 10%. So then another mode of treatment would be medication. So there are lots of new medications that are coming out which are being used now and in weight loss. And then there's bariatric surgery. So with the weight loss drugs, if we go to bariatric surgery, you can get about 20 plus % body weight loss through bariatric surgery. And you're getting 5 to 10% from the lifestyle. So in between is that gap has been filled by the pharmaceutical things. So the first sort of one that came out was liraglutide,
liraglutide, which I think it was roughly about 8% body weight loss, and then semaglutide has come out, which is Wegovy and Ozempic, and then now there's the new one, which is tirzepatide, which is Mounjaro, which now this is, you can get sort of 18% body weight loss with that. So yeah, so very successful.
Yeah. With those, do you tend to, I mean, I'm assuming it's different for every person, but when you say 18%, I take it that's over sort of an extended period of time, not too quickly.
Yes, so I think so what that is that when you have reached your maximum, so at the maximum dose, and the studies were for like at the end, so looking at 68 weeks. So sort of just over a year and a half really.
Yeah, because I noticed a lot of social media comments about these things, and people sort of do it for a couple of weeks and wonder why they've not lost a couple of stone. And yeah, so it's more a healthier sort of long-term couple of years than figure out where you are. And
yeah, so with the dosing, you have to increase the doses gradually. So every month, take from Mounjaro, for example, start at 2.5 milligrams, and then the next month you go up to 5 milligrams, 7.5 milligrams, up until the dose at which it's most effective, which is at 15 milligrams. So that's going to take 6 months to get to that dose. You'll begin to see results probably around about 2 to 3 months, but then once you're on that treatment dose, then you'll see more significant weight loss.
Yeah, that's one of the things that I don't think it matters what they're doing to explain. Is that I think nowadays in society we're used to having things as soon as we want it.
Yeah.
And I think I've seen it, whether it be through weight loss schemes like Slimming World, whether it be through bariatric surgery, or whether it be through these sorts of drugs that I'm like, Mark, we're very impatient as people, and one of the things that me and Mark say quite a lot is that this is a lifestyle change that we need to make. Just thinking out loud, really, I just think we need to sort of slow it down and look at it as a longer term issue that we're going to solve.
Yeah, definitely.
Yeah.
Because I suppose the other thing is that, so if they're more effective when you're doing the lifestyle changes as well. So if you're taking the injection and you're changing your diet and you're doing your physical activities and you're sort of putting the behavioural changes as well, so they work more effectively. And also, I don't know if you were going to go on to this, is what you do when you come off them.
Yes.
If they're only licensed for 2 years.
Yeah. But as I've said, with a lot of sort of weight loss techniques, and like I went on the Cambridge weight plan, and that's how I lost my weight. And I've now finished that weight plan. And so for me, it's like, how do I manage going forward? And so I've spent a lot of time just sort of researching sort of how to eat better and everything like that. And I think with every weight loss process, probably the bariatric surgery, if you go back to these old habits, it will just come back to bite you in the bum again, and you'll be back to square one. And I think it is so important that you do take that time to really educate yourself and work out how you're going to live your life going forward. It's rather than, it's not just a quick fix, I'll press this button or take these diet products for like 6 months and then that's it, I'll be a new man, and that's my problem's gone. It doesn't work.
Does it?
But what I think they are is they're a great opportunity. They're like a medical intervention that give you a chance to get back on track, I think. And because you're absolutely right, because I had gastric sleeve, and you're right, I lost around 60% of my body weight, I think they said it was. But now I could eat maybe not as bigger portions, but I could eat far more biscuits, cakes, stuff like that than what I could if I had dense foods like chicken, meat and stuff. But I suppose those 2 years of that enforced change gave me an opportunity to say, well, actually, I need to address my lifestyle. I need to start playing football more. I need to start doing things, and then hopefully, like I say, that continue that journey with better habits, because it takes about a month to break a habit, and start with at least.
Yeah.
But then if you do it for 2 years consistently and get into that habit, then you're more likely to have a much better long-term successes. So yeah,
So how long's it been now since you had your surgery?
Just over 2 years.
2 years. And did you notice like when you had it, did you notice straight away that you, like you said, the food noise, is that just went?
No. Yeah.
Oh, really? No, that didn't happen.
No. So post-surgery, I think you didn't want it out of me. It was very hard to get back onto food, but it's even now, I still will dish up bigger portions than what I can eat. And it's strange because you'd think after 2 years, you would have learned that actually you need maybe a smaller plate or even half the plates for the food, but it's still something that, but interestingly, there's a diet that they put you on beforehand, which I don't know what it's actually called, but we called it a liver shrinkage diet.
Yeah.
And I very nearly cancelled because I paid for the surgery myself. I went privately. I very nearly cancelled it because that was such a good diet. And what I loved about it was the fact that it's like you can eat two of these a day, 3 of these, and it just basically took all the thinking of food away.
Yeah.
And I think because the surgery was coming up, and you know that you need to do this because surgically it's very important to shrink your liver. I don't know, but I lost over a stone in the 2 weeks beforehand, and the diet, I didn't find that hard. That's really strange, and it really got me thinking, well, what am I doing? I'm making the right decision because obviously I can do it.
Yeah.
But I obviously did go in with Henry in the end, but yeah.
So going back to Mounjaro and the skinny jab as a whole, recently the government announced they're planning on piloting Mounjaro to help people get back to work. Can you tell us a bit more about that?
Yeah, so it was literally a couple of weeks ago. I think since Labour have come in,
Yes.
things have just taken off. I think it turns, I think they've looked at the obesity and just said, right, we've got to do something about it. It's costing our country lots of money, as it was quoted. A healthy population is the foundation to a stable economy. So but basically what they're saying is that it's not fair that only the people who can afford to pay privately for the weight loss injections are getting them. That's just that's inequality. It's not fair that should happen. So at the moment, I think it's something like 35,000 people are in the weight management services, but 4.1 million people would be. So sorry, just to go back, as a GP, you can't prescribe the weight loss drugs. That you would have to refer a patient to weight management services, and the services across the country are really sketchy. So they're very variable depending on where you live. Some services are so overwhelmed that they've actually just shut down. So they so there's a review and with the Obesity Health Alliance, who said that it's not right. This needs to all be reviewed. It needs to we need to look at our weight management services, and it needs to be equitable across the board. So so the demand is massively outweighing the supply. But there has been a pilot which is coming out, and it's actually in Greater Manchester, where they are looking at who is eligible for the injection, and then looking at a way to supply that medication to those people. So Mounjaro is different to Ozempic. It's a dual agonist, so it's a GLP-1 and also a GIP. It works on two different receptors. Okay. So it's more effective. So that's why they've gone for that one. And also the evidence shows that it works even when you have quite basic diet and a physical activity support. So therefore it's something that could be done in primary care rather than having to sort of wait to be in specialist weight loss clinic.
Yeah. Oh, so you think soon it will be just a case of go to your doctor and you can get the prescription for the jab?
So it might even be, well, we don't know that yet. So they've said that, this is a good drug, it can be used for weight loss, but we need to get it to more people, and it should be done on the NHS. So it's been approved by the NHS, but now it's like, right, how do we do that? And so they're looking at possibly doing it primary care rather than secondary care. And we're not sure who's going to do that. It could be maybe specially trained nurses who could do it, or prescribing nurses, or it could be pharmacists, or primary care, being GPs, or people who are specialist trained in obesity medicine. So, yeah.
It's often been described as a game changer. Would you sort of agree with that as a statement? I
think it is a game changer for people who are living with obesity. So, I would love it. I would love us not to have to treat it. So I would love it if we could prevent it from in the first place. But for people who have got diagnosed obesity, it can be a game changer to them. So, if it means that they can then have more physical activity, they can perform better at work, they can, happier in themselves, then I think it can be life-changing. But then what do you do after it? What do you do when your 2 years has finished?
Yeah.
What are you going to do then?
So after 2 years, you cannot take it anymore?
Well, it's not licensed to take after 2 years. So, so it shouldn't be prescribed for longer than 2 years. Because that's what the manufacturing, how it has been manufactured.
Yeah.
And we know that when you stop taking it, your weight goes back up, and within a year, 2/3 of you want to regain 2/3 of your weight. So it's not just, so that's why it's important to address the environment, because it's not only going to prevent people from becoming obese, it's going to also help the people not to regain the weight that they've lost.
Yeah, absolutely. So you need to address those problems.
Yeah.
So, put you in that position, I suppose, during that 2 year period.
Yeah.
Just try and build those habits, a good lifestyle.
Yeah, and that's why it's important that the government needs to do something about the environment we all live in. And so, and with the report that came out from the House of Lords, saying, right, this is not the individual's fault. It's not your fault. It's not my fault that I'm living with overweight. It's the fault of the food industry, because they have created products that are hyper palatable, that make you want, you can eat loads of it before your brain's registered them.
Ultra processed food.
Yeah. They're engineered to be
overconsumed. Yeah, it's crazy, and
we're going to cover that on episode 2, can't we?
Yes.
That'd be a good one.
Yeah, absolutely.
But I think, going back, I think it was 93 billion you said. Actually, do you know what? Even if you're not overweight, even if you've never suffered with obesity before, it benefits, I suppose, this drug being put out to it, or it benefits everyone, because hopefully it will reduce the impacts of obesity. So,
yeah.
And it will be a saver in the long run.
I mean, I suppose from, I'm a lifestyle musician, so I would love, obviously lifestyle is changing your life, trying to implement healthy habits for a lifetime is what I'm about, really.
Of course.
But if, for me, if I'm seeing someone in my clinic, it's about the individual. So, everything should be personalised. It should be person-centred. Who's the person sitting in front of you, and what's their struggle, what's their story, what do they want, what's their goals. So I don't want everything to be about medication, but it's a great tool to use on on a personal level if that's what someone needs.
And that kind of reflects what we want to talk about. And when we interview sort of big losers, it's clear everyone's weight loss story is different.
Yeah.
People achieve in different ways. They didn't have the same start, and they don't have the same ending. And so, it's very much personalised, and I totally agree on.
I think it's important to celebrate your wins as well. When you are doing well, when you're making those changes, it's important to shout about it because a lot of people need to hear it. And it's almost then the reverse of the stigma as well. We should be removing that stigma, but also celebrating when people are achieving.
Yeah.
And I think again would have the reverse, the stigma, don't flare. Yeah, awesome. Well, just a final question to finish off. So, for someone listening to this, and they are sort of their BMI says them they're suffering with obesity, is there a sort of a first step that you would recommend that they take? Is there a course of action that they've listened to this, they might think, right, what do I do first?
So I think the first step would be to get help. So the commercial weight loss programs they work, they definitely work, but only to a certain degree. It depends on what level of obesity, how it's impacting you, how is it impacting your life. So, primary care would be go and see your GP and go and talk to them about it. And, and if so we, as I mentioned before, as a man, only 10% of doctors refer men to weight loss secondary care. Is maybe insist on it, if it's in your area, and to say, look, actually, I've tried this. And so what would probably happen first of all is that they would refer you to a digital weight management scheme, which is very effective. But if that doesn't, or if your BMI is higher, if it's sort of over 40, or you might be looking at medication, you might need to look at bariatric surgery. So so I think the first call would always be your GP, and then hopefully they would direct you to the appropriate services in your area.
Awesome. Okay, I think we're out up there, Lisa. Thank you for your time. And we'll join you on another episode soon.
Okay, thank you. Thanks.
Thanks, guys.